Next Gen Patellofemoral Cartilage Repair with our 2027 ICRS World Congress Chair Dr. Seth Sherman, Associate Professor of Orthopedic Surgery at Stanford Medicine, in a coffee break with Dr. Jari Dahmen, Amsterdam Medical Centers, University of Amsterdam. My name is Tako Shima, and this is On The Go, the podcast all around orthoregeneration.
So I'm happy to be joined by Dr. Seth Sherman on a new podcast of the ONtheGO podcast. And in this podcast, we'll talk about next-gen patellofemoral cartilage repair, but not before we get to know you a bit better. First of all, you've already been introduced by Taka, but could you shortly introduce yourself, your working place, and then we'll get into the coffee questions after.
Absolutely. Well, I'm excited to be here with you. I'm Seth Sherman. I'm an associate professor at Stanford in California, and I'm a team physician for our football team. I run our sports medicine fellowship program. Very passionate about patellofemoral issues and knee joint preservation, and so look forward to this chat.
Perfect. And you're also heavily involved in the ICRS. I think that's where we saw each other in Boston, if that's correct.
Absolutely. Yeah, I'm very heavily involved with ICRS. I'll be helping to plan and execute with our colleagues the next meeting in Europe in 2027. So looking forward to that as well, and looking forward to all of your input on that meeting.
Yeah, looking forward to joining you on that team. We'll see how that goes, and happy to be hosting that event in my home country, the Netherlands. So definitely looking forward to that. On the ONtheGO podcast, we always ask our guests how they drink your coffee. So could you tell us a little bit more about that? How, where, how often, how much?
Yeah, so I'm not addicted to coffee. I've just been doing it my whole life, right? So, but I drink my coffee like in America, large. So that's numero uno. And I do these days trying to be more health conscious. So black coffee is typical for me. And when I'm doing some sort of like intermittent fast or keto, I try to use just stevia. So it's a little boring, but a lot of it with stevia only.
And what about on a OR day or an outpatient day? Is that you have your coffee to just hide away for a second and concentrate on the procedure, or how does that go together with your team?
I'll be honest here. I do typically, it depends if I have small cases and I'm going, room to room, then maybe won't have as much coffee because you're busy. But if you have a little time between, you kind of get a little reward in between, but not full cups in between. That would be crazy. But I try now to drink a little bit of water. I'm at least understanding that that's a good thing. But more coffee, and then shifting towards the end of the day, sadly, to Diet Coke. So, life of a surgeon.
Classic. Yeah, classic. All right, great. That's good to hear. You already introduced yourself a bit and where you're currently based. But we did some background check on you, and we saw that you're coming from a third generation team physician. Could you describe a little bit more on how that path has been and how your family has gotten into orthopedic medicine?
Yeah, sure. I was really lucky growing up. I basically grew up on the sidelines of a high school football team in Brooklyn, New York, with my grandpa. And he was a general surgeon, but really a community doctor, and one of the first team docs, at least in New York City back then. So literally my Saturdays, we'd go fishing early in the morning. We'd go cover the games. We'd go to Nathan's, the original, for hot dogs on Coney Island. And then he'd open up his clinic, and all the teams would come with all their injuries. And before the newspapers would say who won and who lost, we'd get all the scoops of the games, and we'd take care of all the athletes together. And so that was really awesome experience. My dad is the first orthopedic surgeon in our family. So he went into it probably because of that experience. And I was able to watch kind of that transition when my grandfather was really finishing up his career. They named the field after him while he was alive.
Oh, wow.
So we were all there. And back then, team doctors were really also like coaches and cheerleaders. So he got pretty involved in telling the coaches and the kids how he thought. He was giving them pep talks at halftime or after the game. So really special, formative time. I love the team doctoring aspect of what we do. It's different than our clinical and surgical and research hat, but nonetheless, engaging with athletes and patients in that level has been one of the highlights of my career.
Yeah, that sounds amazing. It sounds like a family tradition going into the next line of genes maybe as well. You're currently based at Stanford. Could you also tell our listeners a bit more on how you got there and what your current role is?
Yeah, sure. So, I kind of could write a book on, kind of where I've been. I started, I'm from the East Coast, New York City. So I was at HSS for my residency. Then I went to Rush in Chicago with Brian Cole and team for my fellowship. And then I stayed almost 9 years in the middle of the country at University of Missouri, literally flat farmland, middle of nowhere. And I loved it. Had a wonderful experience there, great colleagues, great surgeries, learned a lot. But it was time to get back to some of my roots and one or the other coast. And we chose California. My wife, Sylvia, and family have been very supportive of that. I had wonderful mentors here drawing me in to take care of the football team, run the fellowship, and frankly, to really accelerate our knee joint preservation platform, to have a PhD in the laboratory, to have clinical research environment to succeed. So it's been 6 years. The weather's perfect here. Every day is sunny without clouds. So I don't really have to look at the weather anymore. California is a little more casual than a New York environment, but still can do efficiencies at the highest level of the world. So it's been a good mix for us.
That's amazing. And so how long have you now been at Stanford?
Yeah, almost 6 years now.
Almost 6 years.
Yeah.
Wow. Amazing. And you're also setting up a lot of research lines, not only on the cartilage and regeneration related topics, also on other topics. But today we want to get to know you a bit more and to know a bit more about the cartilage injuries of the patellofemoral joint.
Sure.
And we're not only going to look at how they are currently being treated or researched, but also take a look into the future.
Mm-hmm.
But before we get into the future, could you maybe tell us a little bit more on where these lesions are located? And which other diagnoses are related to the cartilage injuries of the patellofemoral joint, and how you approach them?
Sure. I think this kind of line of thought is evolving for me. So what I'm saying here with you probably won't be exactly the same as what I'm thinking or saying in 2 to 5 years, which is exciting. It also points out that we don't have the perfect answers on how to treat these patients. So there's different tools in the toolbox across the world, and you may not have the same cartilage restoration options that I have, but I think the principles are the same, and we'll kind of go through those. Just got to take a step back, and there are a lot of mentors that are important to me in the cartilage space and in the kneecap cartilage space, like just names that, really have formed opinions. Of course, Brian Cole, but also Jack Farr and John Fulkerson, and then some across the pond, Elizabeth Cohen and others. So the list goes on and on. Christian Latterman, Andreas Gamal. These are names and these are forward thinkers in PF, Bert Mandelbaum, Bill Bugby, and others. So we'll keep kind of giving you a little flavor of all these wonderful people who have tried to figure this out. I guess to level set also to start, Bettina Hinkle and I looked at a systematic review of all the different cartilage restoration options for the kneecap. And if you do stick to those principles, then you can get good outcomes with low rates of complications. So what are the main principles? And then we'll kind of dive in. I think before you get laser focused on the cartilage lesion, you need to look at the person, you need to look at the limb, you need to look at the joint specific factors, then map out the defect or defects, and then make a plan. And so that really speaks to the importance of load or unloading and alignment or malalignment and stability and soft tissue balancing as major principles to get it right. And so I think with that kind of preface, we can kind of dive a little bit deeper.
Yeah. So with those other aspects that you mentioned, which are probably even more important than the cartilage lesion itself, how has your approach changed over the last 5 years? And could you give us a little bit more information where it's going?
Yeah, I think
in the next 5 years.
Yeah, I think for example, if you have the classic distal and lateral lesions on one or both sides of the joint and malalignment, you can do a standard Fulkerson, an anteromedialization, and not treat the cartilage and expect 87+% good or excellent results, at least in his hands and frankly in ours. if you have central, medial, pan-patella, bipolar, or some variations, then you can correct alignment through osteotomy or otherwise, but you have to also restore the surface to try to replicate those outcomes. So it gets a little more challenging. And so those are good, just key principles to start with, but that's not the whole story. I guess in general, for me, if I'm doing a surface-based procedure, like a cell-based repair, I'm more apt to want to optimize or change the environment and unload through osteotomy. Whereas if I'm doing a structural graft, like an osteochondral graft, then I think potentially, especially if they don't have major outliers of measurable malalignment, like that we can say you're clearly off in valgus, or you're clearly TTTG is 25 or alta, if they're kind of in the middle here, maybe if we can do an osteochondral graft in some of these 30, 40-year-olds, that's a very mature hyaline construct, more like a tire change. And maybe they wear that out over a decade with good or excellent results and avoid the osteotomy. So we don't have great data to back up those kind of differences, but I think philosophically, a lot of us are thinking in those ways.
Yeah, and so you're really individualizing your treatment algorithm to the specific patient. Is that something also that you're interested in with regards to building a big database that you want to aim to, for example, next 10 or 20 years, really get that evidence-based individualized treatment for that single patient?
Yeah, I think there's nowhere more than patellofemoral in the knee space that would be ripe for and is ripe for machine learning and artificial intelligence to help us. My hope and dream, and what we're kind of moving towards here, and with collaborators, Adam Yankee from Rush, the Jupiter study group, and others are really trying to hone in on the different variables and use sophisticated shape models, for example, et cetera, to map out what might be the best plan for each individual patient. My goal would be to build a kneecap, like an app for the kneecap for pre-surgical planning. I think there's so many things that we weigh in our head and try to push you one way or the other. Non-surgical versus surgical is the first decision. And then what is the least amount of surgery you might need to do for the maximum gain without doing harm? And those variables really need to be studied, modeled, but you need team members across the world. You need inputs of pre-surgical and post-surgical outcomes, plus their imaging, plus their history and physical findings, and time in follow-up to really crack this. So it's a lifelong adventure, but it's more than started. And I think that's kind of the way we're going for sure.
Yeah, and I think that also brings us to my question to you with regards to research projects on this specific topic, because this is the way forward to learn in 10, 20 years to really individualize it. What are some current interesting research projects that you're doing on this joint and this specific diagnosis?
Yeah, I think through the Jupiter study group, that's multi-center prospective collaboration. So there's different arms of these studies, but that's a good way to pool large information of our current trends of how we're treating patients. It's really just a real cross section of at least the American group of how we're treating cartilage, how we're treating soft tissue and bones. So that will give us power to fuel the beast of the machine. In the future. Of course, we have our prospective databases, so we're always collecting PROs and X-rays, MRIs, sometimes CTs on these patients. A huge line of research for me, and where I think I'm, getting enough longer-term data to start leading is with some novel techniques for tibial tubercle osteotomy. I learned a wonderful modular technique from Al Merchant, and it's basically a little different way to think about how to do TTO cuts, and really you can customize the plan to the patient, whether you want to do anterization, distalization, medialization, combination, or anything in between. It's also seemingly more of a rotational osteotomy if you look at it more carefully. And so I've done well over 100 patients now, many over two years, some 5, and we're reporting actively on this group. They're, of course, a grab bag combined with cartilage restoration, and also, work on the trochlea, etc. So the shape modeling work really interests me in a tremendous way. And then, of course, as we'll get to in a little bit, we're fortunate here and in other places to really be able to take on investigational studies through the FDA and try to push the boundaries of what's next, right? So what's next in PF? Cartiheel Agility, for example, was FDA approved, and that's good for trochlea lesions. Cartistem is an umbilical cord-derived blood, stem cell study that's upcoming, which is more for OA, but also will cross over at least to the trochlea as well. And so there's a lot of cool things on the horizon.
Yeah, and that also brings me to one of my first questions on the third generation physician. If you take into if you put yourself into the position of the fourth generation physician, in that sense, try to imagine yourself in 30 years. Where do you think, if a patient comes in with PF lesion onto the outpatient clinic, how do you think we will approach those patients?
Yeah, I think it'll be hopefully we'll be able to find out those specific metrics and inputs that are important that drive outcome, so we can collect those as humans with our hands and also get our imaging and get it into a system. And then we can kind of risk stratify, and then we can have a good discussion based on past experience and projections about the different pathways. If you did a MACI plus or minus a TTO, if you did an OC allograft, or if you went down a novel pathway, or if you did non-surgical treatment, what's your risk of progression, and everything in between, and hopefully have individualized, thoughtful plans. I still think that they'll need to be borne out, with us clinicians. And then I think we need to, be able to execute precisely, and all of us to be able to deliver the plan similarly and with precision. And that will require, at least in my generation now, patient-specific instrumentation. I think is really helpful. And then I think not too far off is going to be robotics to help us with some of this side of novel structural, synthetic cartilage, or growing tissue engineered, or patient specific. I mean, the sky's the limit on all that, but the time frame for those are pretty long, for each individual new thing. We're not getting a billion new things every day. So, I think the concept I just talked about we're moving towards, and we'll get there. What tools we plug into that, and what we're actually able to get into patients, I think is TBD, to be seen.
Yeah, and maybe just a blunt question, but do you think we'll still operate our patients in 30 years, or do you think it will be a personalized injection?
Yeah, no, I think the more we do this, if we can get in, get out, harness the power of biology, fine-tune whatever biomechanics we need to, but not more than that. Do no harm, but accelerate healing response. I think that's the future. So certainly, if I can take care of many of these problems in a less invasive way in the future, I'd be open to that. I think it's probably going to be a hybrid. You're going to basically need to utilize biologics to improve our surgical responses and outcomes, and not necessarily to substitute for the need to correct some of these aberrant issues.
That's very cool to hear. And I think also just trying to think forward towards the ICRS in Rotterdam in the Netherlands, will the maybe you can tell our listeners a little bit more about that, to see if they can hear a little bit about the upcoming program, maybe some insights already. Do you think patellofemoral joint will be a big topic in Rotterdam?
Well, I'm one of the two program chairs, so I sure hope so. And I have a little bit of influence, and our wonderful president, Christian Latterman, of course, is a passionate patellofemoral expert as well. But I think this last meeting that was put on was with Simon and Sylvia was just incredible. The energy, enthusiasm, excitement, forward-thinking nature, collaborative nature with industry partners and with each other, surgeons and scientists, I think was the best yet. And so that gave us runway to see what really worked, what sort of worked, what we should do different or better. And I think with Anneke and the leadership and Christian's support, I think we're able to take some kind of leaps and chances that we might not have been able to do in previous ICRSs years past. And so I think it'll be a lot of the same, where you can go to get all your information on joint preservation, but I think a lot more kind of engagements and novel methods to collaborate, communicate, and learn, like small group sessions, think tanks, etc. So that's probably the only teasers I can give for now. You can have me back as we get closer, and I might be able to divulge or leak more. We're also looking to harness the power of our younger members or future members, and to include that generation as much as possible. Of course, to lean on the heritage that makes ICRS great and will continue to do so. And then lastly, really looking outside ICRS to find those world leaders in the hot topics that we care about, bring them in so we can get their perspective and let them know what we're doing, and also they can give us insights on how they might be thinking through the same problems from a 180-degree different position.
I think that answer has just given our listeners.
They're all coming now.
They're all coming now. They just started to.
I can't guarantee
to organize it.
You got to talk to me.
No, that's amazing, and I think that especially that also speak to its word for our younger listeners for the On Foundation, who will be able to as future members of the ICRS and as younger members of the ICRS be happy to attend the conference, maybe by support or with the help of the On Foundation.
I'll just say one other thing that you probably could attest to also. There is no better group of people than the joint preservation people, who are like all, because it's very hard. So most of us are very humble and willing to have these open and candid conversations and don't have it all figured out.
Yeah.
And so when young people engage us, and when I was younger and engaged my mentors that I described and others, they're open arms and they're so excited to have these types of communications and discussions. And so that culture, you can't fake that kind of culture, and it's really present in patellofemoral. It's present in cartilage restoration and joint preservation. And so for those young people who are out there, it doesn't need to be, this hierarchical, crazy, cutthroat, insane orthopod kind of situation. It can be what it is, and we can all learn together. And I encourage you to, prove that for yourself by engaging with them.
Yeah, and that with that being said, I think you already gave our listeners a very good tips and tricks and advice on how to get there. What other advice do you have for our younger listeners who are clinicians or researchers in this field?
Yeah, I think some great advice from mentors. It's a marathon and not a sprint, right? You're not going to accomplish all of your goals all at once, and so I think that just really understand that it takes time to build up your practice, to build up your network. I also think you should put yourself out there and seek out opportunities to think and learn. If you can go be a junior faculty at a course of interest, do that. Get in the lab, teach the younger people than you, engage mentees and mentors 2 to 5 years above you, especially those who are advancing, actively. At least initially, you can always partner with seniors and write chapters and reviews and systematic reviews, and then you can build up your own clinical information so you can ask the right questions, and just keep it simple, and don't shoot for the moon all the time. Like, just hit the little things that matter in all arenas. And I would say also, these days, well-being matters, right? Conserving energy matters. Like, doing things we like to do and that we're passionate of brings energy.
Yeah.
And really getting consumed by things that we don't like to do burns energy and promotes burnout. And so we're all just hypersensitive to that. And like, these types of things, and going to ICRS and doing a podcast with you for a half hour, build energy. And I think they should seek out those things in their practices, in their research, with their family, in their sport. That does that, or their hobbies that does it for them.
Amazing. I think that's great advice for not only the younger generation, but also the older generation. Hopefully, also them listening to our podcast.
Thank you.
Just maybe a last personal question to close our great podcast off, and that's maybe a bit more of a personal question. If you could have a cup of coffee or a cup of tea with one person in the world, he or she might be dead or alive, who would it be and why?
Oh boy. I don't know. Let's maybe I'll think on this for a second.
Yeah, of course.
Yeah. I think there are a couple, but I think the one that probably stands out, Michael Jordan.
Yeah.
I just remember I was a Knicks fan growing up, and seeing his presence, and I also helped, Cole and the team take care of the Bulls. So, I came around to liking them, but his excellence is just palpable, and it's as close to a human god that I've ever seen in a place. And really, as importantly than that, I just wanted to understand how he approached his excellence and how he prepared and what was going through his mindset. One thing that stuck out from his book, for example, to score 32 points a game, which is very high, he only had to score 8 points a quarter, which is not high, which is 4 or so baskets in a 12-minute period. So if you think about it that way, then he should be scoring more than that every game. And so philosophically, getting inside the brain of genius like that in any field, but to perform on such a high level, and to just really be the best at your craft, and to pay it forward for the next generation of basketball players who arguably may have stepped it up even more because of him, and just to be an icon for your entire generation is just pretty cool. I mean, I could probably fill a half hour asking him.
That's amazing, and I think thinking about that and thinking how you got to learn more about how his brain works in that sense, and the way it translates to the younger generation also really speaks for the OntheGO network.
Absolutely.
That's great. Thank you so much for being a guest on our podcast. We really enjoyed it, and talk to you soon for the ICRS.
Thanks to the On Network for doing what you guys do, and we'll see you in 2027.
That's right. Cheers.
Cheers.